Right folks, John, thanks very much. So what I'm going to do today is go old school, use a bit of a whiteboard situation. And when John asked me to do these talks, I do one or two a year, I tend to pick things which are on my mind at the moment because it's right at the front of my mind, it's really sort of something I'm passionate about, and therefore actually doing something like this formulates in my mind as well what I need to do. So it's actually work for me I'm doing now because it gets my mind sorted. So it's interesting you should say then, John, about education and training. So I've been a consultant for 12 years. And what I'm in the zone now doing is really bringing on other surgeons in the pipeline of liver transplant. And so what I'd just like to try to talk about is three things today. One is a little bit of a brief plotted history about when I started, qualification from medicine here. And this is a technique that actually someone told me, and his name was Dave Browell, and was a surgeon over at Queen Elizabeth when he was a trainee surgeon then. He qualified from medicine up here, and then he had a piece of paper rather than a whiteboard, and he said, right, okay, there's a path going all the way down there, and down there you become a consultant. And actually that's quite a long way, and you've got lots and lots of different things to do. And clearly you become a consultant in lots of different avenues. And I really wanted to do surgery. I'm going to come back to that in part 2 about inspiring people to do surgery. But I just wanted to briefly go through this, not to sort of let you know what I've done, because I think this is the path that people just have to do. And the reason I want to tell you is I want to just to get this down in my mind so then I can help people who are travelling this path. Does that sort of make sense? So I'm not doing it to say, oh goodness gracious, it's done really well. This is what people just have to do. So you start off with medicine, and then you do your F1 year, which is your foundation year. And then what you do, if you decide you want to do surgery, you went into the old, that was called house officer, not foundation. Then you went to an SHO, senior house officer. Do you remember those terminologies rather than foundation doctors? And that was in surgery. That was a central surgical rotation in Newcastle. Now then there was a really big step to do. That first big step or hurdle was to get on to the specialist registrar training program. And to get over here, to get from there to there, it wasn't just Friday to Monday, Friday you're there and Monday they get there. This assessment process was about 16 to 1. It's not 15 to 1 because that's a program, so it's 16 to 1. It's 16 to 1. So actually, you can imagine there's 16 people going for one place. That's going to be pretty competitive. So what people have to do in this zone and before was come out, and what I did was I did another degree. So I did an MD, which is a research degree, and that was with Richard Charnley. And that's where I got my interest in pancreatic surgery and cancer, because I worked with him and did an MD. I'd also, during medicine, I'd done another science degree called a BSc, so a Bachelor of Science. So I'd actually got a medical degree and a science degree. And of course that adds in to the situation that you've got an MD, presentations, publications, to then go to the assessment centre, National Assessment Centre, to become an SPR. So that is quite a big leap number 1. And that's something I want to come back to about how we can help people get over that. So once you're on to the SPR, that is 5 years. And then you think, well, okay, you're an SPR, is it the Friday, Monday into a consultant land? And the answer to that is clearly not. And there's a massive, massive gap between finishing your training, which is, let's put that there, exam, 2-day exam, 2 full days of examinations where you go and see patients, have to examine them, someone's examining you when you're examining a patient, vivas. Mine was in the glamorous city of Swansea. Anybody been to Swansea?
Yeah.
sort of average. Industrial. So I was there for 2 days. So you have your exam, and then the government says, right, okay, you can become a consultant surgeon. However, I view this land here, I call this the land of the training, and I call this the island of the consultant. And actually there's a sea here. There's no maps, there's very few maps. There's no stars. And you've just got to get there.
With a flat earth.
With a flat earth, you've just got to get there. That is quite a tricky situation. And I'd like to say it's a differentially tricky situation depending what you want to go into. So, okay, let's look at the northeast. If you want to do a benign, general, abdominal, surgical job in a non-specialist centre, I'm not being, this is just how it is, Darlington, Durham, James Cook, you know, all those are the centres, then that distance is relatively small. If you want to work in a specialist centre and you want to do something like liver transplants, that distance is a long way and you have to get a lot of stuff. I'll just say stuff, we'll come back to that, to be able to get there to do liver transplantation. And this comes right back onto the point, the second point, the second thing I want to talk about is helping people get from this place to this place, because it is pretty tricky. And so what I'd like to do with my colleagues is make it a little bit more directive about giving people guidance, mentorship to actually do that. So people set off, what's the danger of not helping them? People set off and get disillusioned, then they lose interest and they go somewhere else. That's no good. If people set off and were brilliant, but they can't quite get there, they might leave the northeast, and that's not good for the northeast. So, having said all that, okay, being a consultant down here is about using this as well as this, okay? So actually, my feeling is we can't be putting people on my boat and me sailing them to this island. They have to do the work themselves, or a lot of it, but just with me and colleagues, giving them a little bit of guidance. Because if you want a consultant to be working in a place like this in the future, then you want people to be switched on, to be proactive, to be able to gather information themselves, assimilate it, and then make an action. Does that sort of make sense? So it's like, you want to help people, but you don't want to help them too much, because you've got, and you look at this here, 16 to 1. If you want to do liver transplants, boy, you're going to be looking, there's, you know, how many transplant centres in the UK? 7. How many jobs come up a year? 1 or 2. 1 or 2, 3 jobs a year in the UK. That's pretty tough. So actually, you know, you're looking at people with a lot amount of stuff, who've got a lot of nous to be able to get there, but do need a little bit of help. So could you see my sort of my quandary there just a little bit?
Where does the FRC come in?
That's your FRCS.
Oh, that's the one you're doing. Yeah.
That's your FRCS, that exam. There is another exam here, by the way, called your MRCS, which is another exam through the Royal College, and you have to have that to become an SPR. It costs about £2,800 to actually sit that, so you don't have to sit it many times. That's another 2-day exam. And then that's member of the Royal College of Surgeons, MRCS. FRCS is fellow of the Royal College of Surgeons. So you have to have those 2 exams. So, okay, right. Shall we come back to stuff? Let's come back to stuff. Okay. The way I'm going to look at that is the way that Dave Browl spoke to me. And I still remember it. It was on a Saturday morning after I finished the ward round, having a coffee. And I think he was telling me this because he wanted me to get a job with the Queen Elizabeth. That's fine. But maybe he was a nice chap as well. he said, right, okay, so you've done all this, you've sort of, you know, you've gone through this, and he talked a little bit about this, I'm going to come back to this. But he said, right, okay, let's just actually turn that paper over, okay? You start here. What do you think I'm going to put here? What am I going to put down here?
Professor.
Well, not quite, but it's retirement.
Oh yeah. Right. Oh, that's the same thing, isn't it?
That's on film. I've heard a lot of jokes from John actually, but that's probably the best one. But when he did that was quite an interesting thing to do, because I've not really thought about that. You know, I was just so focused on, once that's it, you're like, oh, God, I've made it. Trouble is, when you're there, if you're the sort of person that's done all this to get there, you don't really put your feet up.
Yeah.
No, you just carry on. And this is quite interesting to me. And he said, right, okay, see you there. I said, what are you going to do here? And honestly, I think I was at sort of this stage. I don't think I've got that. I was sort of here. I hadn't really thought about it. And he said, right, okay, so there's various different things as a consultant you can do. You're going to do your job. You're going to operate. That's your base stuff. So you could just, and he drew it in like a series of columns. So he could just put graft. You could just work hard on doing loads of operations, seeing loads of people in a clinic, and doing lots of wardrobes. So you could just do that if you wanted to. Not to be really recommended, because you probably get to about here, you get disillusioned, burnt out, your productivity goes down, you end up being pretty miserable. You really do. You probably, early on in your career, you do a lot of operating, you get stuck in, you do lots of operations, but then when you get a little bit older, maybe like me, 12 years in, you sort of think, well, I've done lots of operations, maybe want to do something else. And these aren't mutually exclusive strands. You can do other bits and bobs. You could do education. You could be a big educator. You could be a big manager. So you could go into hospital management. You know, the hospitals need people to run them, and actually a lot of the time, people who are clinicians are probably the best place to actually run them.
Clinical director.
Clinical director, 100%. So I'm head of department for HBB surgery, Derek's head of transplantation. Possibly at some stage I'd quite like to be clinical director. And then maybe even assistant medical director. You never know, the medical director, I don't know. I'm quite interested in management. Another stand, research. You know, a lot of people are interested in research. Now, politics down there now, okay? That is not Boris Johnson type of politics. That is, when I'm talking about politics, I'm talking about internal and especially external as well. Because if you look at a centre like this, which is a specialist centre, you have to have people who predominantly look into the centre, work out the machinery of the centre, the little cogs to make it all work, protocols, guidelines, problems with staff, that sort of stuff. And then you want people who actually are externally looking, more externally looking. So what they do, they go to national meetings, they have a national profile, they make sure that we get the slice of the pie in Newcastle, that we should get the slice of the pie. They have committee representation on national panels, which means that if the government's handing out some cash for some projects, we've got someone in that tent looking at it like you do to other people, you know, you're in it. And you have to have a mixture of those people who are prepared to sit on a train a lot and an aeroplane and whatever else, and perhaps as an entire team we have to say some people may not be here quite as much as others, but what they are doing is as important to the department as a whole. Does that make sense?
Yeah.
And this is sort of this is a strategic way to look at the department. And the reason why I'm bringing that in before I talk about that is that you cannot be brilliant at all these. Impossible, you haven't enough time. you just haven't got enough time. You probably major in one, minor in another, and then support in other ones. So, with this in mind, if I'm if I'm providing a sounding board for people here to get stuff to be successful here, I say, which one of these or two of these are you going to look at to be able to get the stuff in there?
Yeah.
Does that sort of make sense?
You've got to be backwards looking, haven't you?
You've got to be backwards looking, 100%. You've got to say, and you know what, you could even, if you were really smart, is you could say, right, okay, I want to do transplantation. There's not many places do transplantation. I'm looking at that department over there. Could be this one, could be Leeds, could be Edinburgh, could be Birmingham. What sort of things do they need out of these for me to be successful? So you can actually stock yourself up with that sort of brief to be more likely to be successful getting something down there. So you can play strategy a little bit. So that's where that brain comes in, to be able to think, oh, that's where the opening is going to be, that's what's needed, I'm going to get myself ready for that particular case. I mean, you can do that to some degree, but you see, everybody's got their own inherent strengths and weaknesses, what I mean, or what they want to do. And I'm really passionate about strategy, and so I love the management side of things, because I think a department needs someone who's going to have a thought process like that, and I go on courses, and I talk about it, and that's how my brain works. I'm really interested in it. But you probably don't need 6 people like that in the department, because it's not going to work. So what I'm thinking about is moving forward, whenever we're building the department, which one of these bases do we need covered? Research is something that actually, it's interesting you should mention that it's probably not been quite as good as it could have been in certain areas. And I mean, you've asked me about that, and my feeling is that a place like this, a regional centre, we have an obligation to do research, because actually we have a gift of these very complex patients, and we've got to use what we can to be able to future knowledge. And I think that our footprint in the university, certainly from a surgical, not a medical side is very strong, surgically side has not been quite as strong as it could have been. And that's not anybody's fault, it's just how it is. Maybe we've just been busy doing other stuff. Everyone's busy, no one doesn't work hard, by the way, everyone's busy. And so, some of the appointments we've made recently, so there's Derek Manners, Steve White, Dave and Derek, then there's Steve White and myself on the same day appointed. So I'm sort of, if you look at it, one of the senior-ish people. But all the people below, a lot of the people below, have quite a research portfolio to actually make sure that we've got a lot of the bases covered. Not everybody, but certainly that's one of the things there.
Why does nobody from the surgical side end up at the uni?
That's an interesting question, and I'm probably outside my brief here to talk about it. And I think probably because there was a footprint in there, and I think people have they've achieved what they wanted to achieve in that arena. Other people from the university have come in; those connections haven't quite been made the same.
The clinicians now at the top, aren't they?
Yeah.
They're all clinicians. Yeah.
So with people like Colin Wilson, who we know, Stuart Robinson, Sanjay, they are John Hammond, all these people coming through have got very strong research ideas. We've got research nurses now, we've got portfolio studies. Portfolio studies means the government gives this hospital lots of money to run the studies. So actually that's good for research in general. We've got biobanks that we've set up. So actually, it's been very good along those lines.
Can I just ask?
Yeah.
Who would be responsible then if there's a vacancy? Bearing in mind that the sometimes you don't know what you don't know. So obviously you've got an interest in, as you say, the sort of the management side, the strategic side. Who would be the overseer who would write the person specification or the job description for someone who they needed to come into the system? Do you know what I mean?
Yeah.
If you're trying to build up that team, that magic team, that contains all of those people with all of those skills, who is the person or who are the people who would have that oversight, that skill of seeing it all?
How do you decide that?
Yeah.
That's a good question. So, okay, so I'll just backtrack a few years. And so what there used to be was a very generic job description which said, you'll be responsible for HBB patients and liver transplant. You'll turn up at a clinic, do an operation, do a bit of audit, do a bit of research. It was very generic, and that's what I applied for, Steve White did. We made it a little bit more specific with regard to when Colin Wilson and Gurab Sen were appointed, but since then, things have changed a lot, and I think it's probably since I've become more senior and realised we need to be more bespoke about things. So who are the persons going to be? It's going to be me, and it's going to be probably Steve White from a transplant point of view, together with Mike Clark, who's the clinical director, to be able to say, right, what does the department need? So, but I wouldn't work in an autocratic fashion. I would talk to my colleagues and say, you know, what do people think? You know, I've got my own vision and idea about things, but I want to take people with me. So I think in the past it was a little bit like, oh, that person's pretty good, let's appoint them. Which is fine, and it works most of the time, because I think if you get the right people, then you're going to get, but actually it's a little bit like, you know, okay, but you know, if you want a centre back, you want a centre back, don't you? You want someone to get their head on the ball. You know, if you want a little dancy winger, you want a dancy winger. You know, so let's write a job description which is a little bit more bespoke.
I mean, what you've got there is really the A team, isn't it? If you get that balance right.
Yeah.
How does that sit with the inspection process?
Inspection of?
Well, you know, when trusts are actually inspected, because that's the big bogey out there, isn't it, at the moment?
Yeah. Okay, so the way that I'd answer that would be that what we have is we have what I call the cake. Okay, so it's like this. So this is tier 1, and on tier 1 there are the clinical skills. So essentially, you've got to be able to do an operation. You've got to be able to be someone with a brain. You've got to have insight. You've got to be able to do a clinic, do a ward round, bring you, the base skills you've got to have. So in fact, if we're looking at inspections, they will look to check that the clinicians have got those base levels of skills. And that comes actually, we're very, very lucky because we've got a, you know, let's just say it's about 20 to 1. We've got a ratio. We can pick the best people coming through this system to get, so they're all, it's almost like that's de rigueur, that's just like expected. You're gonna have people like that. Not always, but the vast majority of the time. So the next one will be clinical interest areas. That's before we get to this. So if you look at the department where I work now, we have liver transplant, put that first. We've got renal, we've got pancreas, transplant, we have liver surgery, liver resection. Probably can't read my writing, apologies, terrible writing.
You might be a good writer for a doctor.
Pancreas resection. Anybody heard of neuroendocrine tumours?
Yes.
Yeah, neuroendocrine tumours, big service. We've just got Centre of Excellence for that, European Centre of Excellence, big service. We've got sarcoma. We've got pancreatitis. Okay. All those areas. We've got things like, I think Pete Littler's come and talked about CERT and ablation. Yeah, CERT and ablation. So CERT, ablation. We've got islets. Heard of islet transplantation?
Yeah.
Steve White? Yeah. Islets. Robotic surgery. Had some talks of robotic surgery? Yeah, robotic surgery. Right. Absolutely. Right. Look at all those areas. Right. Rhetorical question. Do you think you could manage all those areas, be an expert in them all, and pioneer them, lead them, and develop them?
No.
Impossible, isn't it?
Impossible.
Absolutely impossible. Ridiculous. Even if Superman worked 24 hours a day, never going to happen. So you've got brilliant people with good skills. You've got to have someone with a clinical area of interest to be able to develop it and take it forward. Remember that goes back to that, doesn't it? Yeah? Stuff. And then within those areas, overlaid on top of that, is your threads, what I call them. What are you going to, what are you going to do within those areas specifically? And then if you can get that together, then that's when you can actually start to cover all the bases within the team. And the way that I look at it is, it's a little analogy I have. And say I'm talking to someone about, and I get lots of telephone calls from people who want to come to the unit. We've got a person coming in November from Cincinnati, who was a UK trainee, gone over there for a fellowship. He's coming over to have a look around. And the way I say it is right, okay, so the way I describe the department, it's like me painting a picture. So I'm painting a picture here, I'm painting it here. With other people as well, just adding in, but I'll be painting it. And I say you're the trainer, I say, John, do you like that picture? And that, you think, you might like the picture, you might not like the picture. Let's say you do like the picture. And then, but the thing is, that piece of the picture is missing. What do you think that is? That's you.
That's me.
That's you.
It doesn't look like me.
Yeah. Just look at it and do anything other shape it. Otherwise, maybe some eyes.
Yeah.
I don't know. You look at that and you think it's not quite complete, but that's the shape that we need. Shape of this, whatever we need in this department. And maybe you're early enough to be able to just model yourself a little. There's a bit of wiggle room, isn't there? It's not super rigid. You can change a little bit. But are you that person to be able to come and actually sit in there to make this picture even better? So that's the vision of the future. That is that's where we're going as a whole team.
So how much do you think we've got a picture that's got a lot of holes in it at present? Because I always was fairly happy. I thought, when I was a governor here, I thought that the hepatology service was exceptional compared to the ones we see elsewhere.
Yeah.
And I wouldn't say there were many holes in it. There's certainly very few never events and, very few mistakes.
John, you know what you are. You're 100% right, and in the way that Newcastle is a phenomenal centre, and I would say that every single trainee we've had and fellow, we've found a consultant job for, but they haven't all got a job here, but they've all wanted a job here.
Yeah, good.
They've all wanted a job here, but we can't give everybody a job. I think what the answer to the question is, yes, we've got all the bases covered, but I think we've had people covering 5 or 6 bases and managing the bases, but we haven't had them able to really propel them forward. And so it's good, I completely agree, it is good, but you see, I'm one of those people that I'm not happy with good. I want excellence, I want to be even pushing even further. Robotics, Steve White and myself with Gurab on board now do robotics. We're the leading centre of robotics, HBB in the country. Leading centre, that's good, I like that. We want to push it even further. There's a new generation robot coming out, so you can't rest on your laurels.
That's right. One of the things that you haven't mentioned, and I know is a big thing, is that all of the consultants in this trust do their own plan, their own budget, and ask for money. That other trusts have administrators doing that for them, but we've always been very light on administration in this trust. And the heads of departments do their own, and that's an additional workload on top of it.
That comes in here. That's one of my jobs.
Okay,
one of my jobs is, we've got, with Gurab, who's the cancer lead now, I was the cancer lead, but now Gurab is, and we've just got a cancer care coordinator to manage the patients. We've also got bids in for 2 more clinical nurse specialists, because we realise that's what we we need to develop the team. And that's this, don't want to put it down, that's this inward looking type of thing. We've got to be able to do that.
And making bids for new things all the time.
And making bids for new things.
Your business plan and all the rest of it.
Yeah, yeah. You know what, I mean, when you're appointed here, where in this training to tell you how to write a business plan?
No.
Nowhere.
And some trusts don't have
Nowhere. What's the most important thing to me now? Okay, doing a liver transplant, yes, but actually more challenging is all this managerial. It's like, oh, it's a different world.
You just described from start to finish, setting up a really well-run company.
Well,
business company.
yeah, perhaps so.
Something like this ever given to third-year students? I mean, as a third-year or fourth-year medical student, seeing something like that, that must give them a tremendous focus and say, I know where I'm going now.
Yeah.
Because many people, many students,
Before
have
they
just
ever
got
get
their
down.
heads down and they're just pushing to get, to get over the first hurdle and the second hurdle.
Yeah.
But that's amazing, all right, and they can, it's
can-
strange to say to someone at 20 or 21 years of age, think of retirement and think backwards from now, but it is so important.
Absolutely. I'm thinking about here. I'm going to be, and I would have stand here and look back and think what I've achieved.
Yeah.
Not because it's not all about me, but I'm extremely driven, and about driven people, there has to be some not benefit to me, but I get something from it.
Yeah.
Otherwise, I wouldn't do it. And that's not selfish. It's just because I think I'm very team orientated. But I want to look back and go, I brought all those people on, and actually, what I want for people here coming in is I want to appoint people who are going to be better than me. No point appointing people who aren't. I want people who are going to be just, standing here in 10 years' time when I'm retired, or whatever, nearly retirement, and say, well, this is the next thing. Jeremy, that was fine, okay then, but now it's like this. Bang, we're going to do it. But that's just to, and I don't want to go on too long, but I can use this one here maybe, or shall I not? I don't know. Shall I? Maybe I'll stand here. I'll just carve out a piece of thing here. And this is something that Colin Wilson. It's not all about me. So it's teammates. Colin Wilson's taken a lead on this. And what we realised that actually the people coming into liver transplant were going, numbers were going down and down and down and down. What's going on? There used to be loads of people, but it's getting a little bit less now. And we thought, well, that's not good. And you can either sort of get the barrels from the apple, or you can go to the tree. And so we decided to go to the tree and start early with a long-term plan. And it's not just, we think we're going to do this. There's a documented pathway that we like to intercept students on and actually give them some inspiration to come into surgery. Starts off with SSS, Student Surgical Society. So that is where these kids are 18, 19, 20, you go in. And I've been in there a few times, Colin's done it, and Gurab's done it, Sanjay's going to go and do it. And you put some big pictures on, you show a few videos, and people are like, oh my God, this is a whole new world. And from that, they can come from some experience in theatre. Next, I know it's all letters, SSC, which is Student Selected Component. So in their degree, they can decide to come and do an attachment somewhere. And if you haven't done none of that, they might not come and do this. So it leads on. And they come for 6 weeks, do a project, write a talk, get some more experience. Next thing is academic F1. So you can get them into HBB surgery, transplantation as an academic F1. Next thing, academic clinical fellow, it's about this level, is in transplantation. And then once you've got them to that particular level, then they're going to be an SBR, interest in transplantation. So you've got to have this pipeline coming through and pump into it all the time as a department to be able to give people that inspiration to do the actual job.
And do you do that with the universities?
Yeah, absolutely, absolutely. Because what we've found is medicine as a degree, the amount of stuff that's goes into the degree now is just getting bigger and bigger and bigger and bigger and bigger. So surgery gets squeezed and squeezed and squeezed. And I think it's not that the students don't actually like surgery, it's just that they don't experience it. And I think their sort of perception of it are probably not people like me. They may be people who've got from television or something, and they think, actually, when they come into surgery with me, most of them, I hope, think, not all of them, think, oh, it's pretty good, quite like that environment. It's fast-paced, it's hard-working, everyone's in it, but you know, you can see your results pretty much straight away.
Music's rubbish, but that, by the way.
Music's rubbish, but you know, that's especially if it's. I don't even allow my music in theatre now. People switch it off, John. Honestly. So that is really, really important. And as I say, Colin's led on that. It's one of his bases he covers. But actually, even though you cover bases, everyone has to support everybody else.
Yeah. Can I ask you about the European Working Time Directive, which I recall very well reduced the number of hours that student doctors and all trainee doctors could only work 48 hours a week. Previously, and they had to be sent home.
Yeah.
Previously, the trainee doctors used to work 96 or 100 hours a week. But the European Working Time Directive ruled that out. It was one of the reasons Transplant TV was kind of formulated, so they could go home and watch a couple of operations. Now, do you think that's does it contribute to the reduction in the number of doctors that we are getting through the system now? The fact that they fail the exam?
Yeah, okay, so I don't think it's a reason why they fail the surgical exam. I think it's a wider question about reducing the number of hours that doctors are in hospitals. So, let's work backwards. So I'm not under the European Working Time Directive. I work.
No, you're above that. Great, that's right.
If you're a specialist registrar or a senior clinical fellow in transplantation HSBB surgery, you probably work over voluntarily, but we can't enforce that. The junior doctors here who are not interested in transplant or surgery, that's fine, because you know there's lots of areas of medicine that need to be looked after. It's an interesting sort of it's interesting cohort coming through now who actually they want to go home on time, and it's which is fine, but it's a different perception coming through. So I think maybe the question is about, can we train people adequately in the 48-hour week? Yeah. So if you're an SBR for 5 years, I think I was the last person, and I did 6 months in Leeds, that was appointed without doing a fellowship somewhere. So you've done this, remember this stuff here? That may include going away and doing something else. It may include going to, for example, going to America, where they work you hard. They'll work you at 100 hours a week, but you'll come back and you've done 100 transplants yourself in a year, 100.
Yeah.
So actually, so I think to get here, we either accept that someone is going to have to continue their training as a consultant, or you go and do something else before you come into this place. In this institution, what we've done is we have a mentoring program, so people start, and if you start as a consultant, you're doing liver transplant, you won't be on your own. There'll be somebody with you, guiding you through it. So, yeah, so hours, yes, but affects more higher up the chain than lower down the chain.
I mean, if we come out of Europe, there's every possibility that directive won't apply in the UK. Possibly.
The thing is about the, for me, because I do a lot of recruitment, part of this job, remember this job, yeah? Recruitment is selection and recruitment, is if I put an advert out for a senior clinical fellow, so that's somewhere between this and this, then if someone is from the UK and they're appointable, they get the job. So there's no one from the UK appointable, then it goes European. There's no one European in the world. So actually, you may have a brilliant person from South Africa who wants to come for a year, but actually you've got someone who's UK based who's just okay. Massive difference, but because they're just above the line, you have to give it to this person. I don't know, I'll leave that with you guys to think about, but I just want the best people here. You know, but I don't want to disadvantage our trainees, but if there's a massive difference, I'm like, well, really?
Yeah, that's right.
So that's the way. That's where we're at with it. I've never drawn that before like that. Actually, all of it. Never, but I might take a picture of that because as I said, it's actually formulated my mind as well.
Yeah, that's good.
It's on John's.
Is there any little place on that diagram for patient and public involvement to help keep the motivation going with those people who are starting to get dissolution and so on, and perhaps moving away from the thought that they want to do liver transplant?
That is a really, really good point. And I think that's... I mean, I think... I can't think of anywhere absolutely specific. I think...
In the threads with education, you know...
It's been involved in things like this,
Yeah.
with the patient and public, so getting trainees involved to do that. I think what happens at this particular stage, when they realise they want to do transplant, they get the bug, they get the desire to do it, and then that hooks in with the patients. I think disillusionment's a very important point, because people can get, God, we're trying and trying and trying and trying, it's difficult. And sometimes when I order that, I say, bring it right back to basics. Don't do anything to try and fill this box up for a month. Don't do anything, okay? Come into work, talk to your patients, do your job, the basic job. If you see whether you can fall back in love with it. If you can, then you get the motivation back for this. If you can't, then maybe that's a serious think about it, and that's where that comes in. I often think, oh God, I've got so much of this sort of stuff to do. It's like, And then today I did a ward round. Got a lot of patients in at the moment. Did a 2-hour ward round. Spoke to all the relatives, and some tough discussions. But you think that rejuvenates you a little bit. You think that's why I do it. That's why I do it. I set all this stuff up so actually you can help the patients. But so if you get too drifted out into all this other stuff, you're away from it, and you lose that connection. So it is important to keep it. Yeah.
Excellent.
So I'm probably going to leave it there, John.
Great
If that's okay. I'm happy to field any other questions, but it's been more of a discussion, which is good actually.
Because you've got
my phone.
the explosion of science and medicine,
Right.
and I'm looking at your box behind your head for Mike. That lot there.
Yes.
Yeah. Surely if you come into doing a medical degree now, but right at the top left,
Yeah.
You just press that.
there's that explosion of potential specialisms, which there wasn't 20, 30, 40 years ago. Is there some strategy in place right at the bottom end to start to give those people that come into medicine at this sufficient time to then realise just how vast it's become? In other words, you're looking at surgery, but within surgery, you've got so many specialists. In other words, the pyramid has still got probably a fairly fixed base, but it goes up, and then there's all these little pinnacles all over the place. I'm confused.com. I don't really know where and how does the students get sufficient experience in the broadest possible context, because within surgery and transplantation you're now competing for that pool of knowledge and that pool of skill on a much wider basis than you probably were 20 or 30 years ago, and that's only going to increase as science and medicine advances. You're going to need more people in that series of boxes behind the head, because those boxes are going to start to specialise as well.
So there's two ways to look at that. One is that you need people who are narrower and deeper.
Yep.
Absolutely. But if you look at what's needed across the country in general for abdominal surgery, is you want people who are very broad and thin. So if you look at the northeast as a whole of 4 million people, then you don't need every surgeon to be able to do liver transplants. Realistically, the majority of people coming into A&E need an assessment of an acute abdomen, whether they've got a blocked colon, appendicitis, biliary colic, a perforation or a bleed. And actually you need someone with a skill set to be able to deal with that. That is the basics. So you need actually 95% of people need to be basics, and only 5% need to be doing this super specialist stuff, which is it's almost like, yes, you do need more and deeper, but actually, if everybody doing surgery went more and deeper, then you'd be like, you know, you'd end up with someone who's the toenail expert, but only the left toenail.
Yeah, well, isn't that the way science is going though? It's getting broader and it's getting more and more specialised.
Possibly. I'll do another talk on that next time.
What, left toenail?
Yeah.
Well, that's amazing. Thank you very much, Jeremy.
No problem.
Now, before I do this draw, I'll present you with your special 25th anniversary LIVErNORTH pen, and this little thing we've started doing this.
Can I just make a request?
Yes.
So this photograph here
It's about
is
25
actually quite a long years old. The amount of hassle I've got today walking around the hospital is, well, I saw someone I was going to give a talk, but it couldn't have been you.
Yeah, well, that's on your profile. That's on your profile on the Trust website.
I'm going to have to check. Okay, promise. But anyway, thank you very much.
That's all right. So, well, you can show people, show your children, that's what you used to look like
Before
they were born. So, there's your pen. This is the last pen, the 25th anniversary.
Okay.
We've raised £1.2 million since we were formed in 1994. So, that's yours.
Brilliant.
So, and thank you very much. We'll have a photograph for the newsletter. Has it worked?
Taken two.
Okay.
Brilliant. Excellent. Okay, then. Thank you.
I'd also like you to make some